Hello everyone. So this is just an optional video to help you get an idea how to approach questions that we're going to be giving you or that you would have on the anatomy exam. Typically for DCOM we try to do National Board of Medical Examiners type questions, it's NBME. They're just pretty similar to them. They're not exact, but the whole point of this is to help you review your anatomy and get an idea how to approach these questions as you go along. So doing practice questions is essential to get a good idea and get effective at approaching the questions. So there are multiple ways you can approach a question of this type. Approach number one, again, there's just multiple ways to skin a cat. The first kind is where you just read the passage, and then of course you look at the question, and then you can think of an answer choice and turn immediately to the choices and answer it. That's typically the most common approach that most students have. I did that in the past when I was in medical school, just the same way. And then as you go along, you figure out there are more effective ways of doing it. But that is one way to do it. Approach number two, you skim the answer choice, you get the context of the question and the passage, you get an idea of what they're going to be asking. Then you read the last sentence, which is usually the leading question. You figure out the question, and then you read the passage and you extract the information that's relevant to answering the question. And then, of course, you go back to the choices and pick your answer choice, whether it be by eliminating or just picking the answer choice based off the relevant information. Approach number three is a type that I'm going to be going over. Most times it can be very, very effective, but again, it's going to depend on the person. But I'm going to use this approach to get a good idea how to lead in and figure out the answer. So this kind of approach, you're going to read the last sentence, usually that's the lead-in question. That gives you an idea what you're going to be looking for as you go back to the passage. So you have an idea looking at the question of what you're going to be looking for. You go to the passage, or what we call the stem, and then as you do that, you already know what the question's asking, so you're going to be extracting clues and relevant information that's going to help you answer that question. And last but not least, you're going to look at the answer choices, and you should have an idea what answer you have in mind before you look at the answer choices, and you should go with your gut most of the time, unless you know for sure that it's definitely not the right answer. So the best thing you can do is practice doing questions, find out what works best for you, and the only way you're going to do that is by just doing more questions throughout the weeks. The more questions you do, the better you'll get at approaching these questions. And what I really implore you not to do is please don't wait until you see the exam for the first time to see your first question for anatomy. You want to start using multiple resources that you can, whether you're going to be using the BRS, the University of Michigan questions that Dr. Hermy gave you resources to, anything that you can start looking at questions and approaching them and see the reasoning behind them and start applying that anatomy that you have learned throughout. Now there are three types of questions that I'm going to be going over. Simple recall is what you probably saw in undergrad. You get a question and then you approach it you recall the information for that one question. It's pretty simple. You'll see what I'm talking about. Then you have what they call one-step in reasoning. It's level 1 or tier 1, what we know as CC1. And at that point, you're given something, and you have to go one step ahead in order to get to the relevant answer, and I'll show you how to approach that. The harder ones are CC2, where you have to go 2 steps of reasoning in order to get to the answer. So you're given something, you go one step, and then from that information, you go one step further, and you get to the answer itself. And so we're going to start with recall, and then go on. So I'm going to give you multiple types of samples, and approach them in a certain way. So if you look, use a highlight here. Okay, so in this question, we're going to look at the question first. So which nerve innervates this muscle? So you're looking for a nerve in itself. So I'm highlighting that itself. Okay, so you're looking for a nerve that innervates, and you're looking for that innervates that muscle. So you have a 32-year-old stab in his back. So you're already thinking about a back muscle. Injury of the systemus dorsi. All right, so there's your muscle right there. The systemus dorsi, and basically what you're looking for is what nerve innervates this muscle. Now some of you are already probably mouthing off the answer pretty quick if you've been studying and looking at the lectures and you got it down. So this is a recall question. You're given the name of the muscle, And in this case, you're asked what the innervation is. Okay? So what nerve innervates the latissimus dorsi? Now, if you know the answer quickly, you can just circle your answer and move on if you got it right down. If you don't, what you want to do is try to eliminate other answers to get to it. So look at the first answer. So the anterior rami of intercostal, that's going to innervate the intermediate layer. So the layer. So that's your serratus posterior, superior, and inferior. All right, so that's out. That doesn't innervate latissimus dorsi. The dorsal rami, you remember the lecture, you went over all the deep intrinsic back muscles of the back, from splenius to multifidus, and none of that is latissimus dorsi, so that one's out too. The dorsal scapula, if you remember, that does your levator scapula and your rhomboids, so that one's out. Long thoracic, the serratus anterior. So you're left with the thoracodorsal for latissimus dorsi. So this is just a recall question. And again, if you don't know it, the best thing you could do is, if you know other answer choices, is start eliminating them. And that will help you out going through. So this is strict recall in itself. You're given a muscle, in this case the name of the muscle, and you're asked what innervates it, or you can be asked what gives blood supply to it, etc., etc. Okay? All right, so sample question number 2. Again, let's look at the approach. Let's look at the last sentence of the question, the stem. So, which muscle would most likely be compromised? All right, so this time, you're looking for a muscle. Okay? Now, let's look at the question. A 30-year woman is undergoing shoulder surgery, so you're thinking about the shoulder. The surgeon accidentally lacerates, that means to tear, so they're tearing something. The surgeon lacerates the superficial branch of the transverse cervical artery. So in this case, this patient is losing the superficial branch of the transverse cervical artery. And again, the question initially, remember, it says which muscle would most likely be compromised, meaning which muscle is most likely going to be affected. So it's a simple recall question. You're given an artery that's damaged, and you're asked for what muscle it supplies. Now again, some of you guys may be coming about it real quick. Okay, so what muscle is supplied by the superficial branch of the transverse cervical artery? And a lot of you guys are going to look at it real quick and get the answer choice. But if you don't, again, you want to look at the answer choices, and if you can't get the answer very quick, then you got to eliminate some answer choices. So you got latissimus dorsi, that's your thoracodorsal artery, so that one's out. Levator scapulae and rhomboid major are both supplied by the actual dorsal scapular artery, or also known as the deep branch of the transverse cervical artery, depending on its origin. But most of the time we go by dorsal scap. All right, so those are supplying levator scapula and rhomboid major. Okay. The multifidus, usually supplied by different segmental arteries from vertebral to dorsal branches of posterior intercostal, etc., etc. So that one's out. So that was one of the muscles that you just had to know was one of those deep muscles in itself. The one muscle that you do know that is supplied by the superficial branch is a trapezius. So that would be your answer, letter E, trapezius. Okay? So, again, with simple recall questions, if you know the answer, remember, you're limited in time when going over questions. So if you know the answer, go with your gut, circle it, and move on. But if you don't, then I would suggest look at the ones you do know, eliminate those, and try to get you your best possible answer to go on. Okay? All right, so we're going to move to question number 3. Again, let's look at this last question here. So which muscle is most likely compromised? So here we're dealing with a muscle. Okay? So your stem says a 32-year-old, it's meant to say patient, but a 32-year-old patient presents to the clinic with a rotator cuff injury. So all right, so we know that there's something wrong with the rotator cuff. So you got to think about those muscles. The physical exam reveals he has weakness with medial rotation of his arm. So there's weakness of medial rotation of his arm. So it's not totally lost. So we got to think about this. So again, this kind of question can be looked at 2 ways. Essentially, this question is asking which rotator cuff medially rotates the arm. So it's basically a recall question. But you can go a step further and say, well, I need to know my rotator cuffs first, and then I need to know what medially rotates the arm. So it could be a level 1, where you're having to go one step further. But essentially, you're looking for what rotator cuff medially rotates the arm. Now, some of you guys may be getting it immediately. You got your 4 rotator cuff muscles. You know exactly which one medially rotates the arm. But again, you want to identify them. So you can identify the rotator cuff muscles within the answer choices pretty quickly if you know them, right? So that's your SITS, S-I-T-S, little t, remember, for minor. So all of them except teres major are your rotator cuff muscles. Now that helps out a lot because you can eliminate one answer right away. So teres major is out. Now, but you got to look at the functional deficit again. All right, so we know rotator cuffs do initiation abduction, they do lateral rotation, and they do medial rotation. So you got to look at the functional deficit. In this case, the functional deficit of the patient presenting is with medial rotation of the arm. They're getting weakness of it, okay? So that means there's other medial rotators still working, but this one medial rotator, the rotator cuff, is injured, all right? So what rotator cuffs medially rotate the arm? In this case, the only one is subscapularis on the anterior side. Remember, infraspinatus and teres minor, those laterally rotate. Supraspinatus helps initiation abduction to that 15 degrees. So what I did here is you just have to look at them and you have to remember what other one. So again, if you're looking at a recall question like this, you look at the question first, which muscle is most likely compromised? Then you look if there's any weakness or whatever they're giving you. In this case, they're giving you a functional deficit. And your job is to apply that attach that functional deficit to the muscle itself. So when you look at this, you can do it 2 ways again. You can actually go by recall and go, okay, I got this. I know what rotator cuffs they are. You can eliminate the rotator cuff that's not, well, the one that's not a rotator cuff, in this case is teres major. And then you can look at the functional deficit and figure out, all right, which one does medial rotation? Subscapularis. If you don't know that, then again, process of elimination. So in this case, you want to remember what the others do. Supraspinatus initiates abduction to 15 degrees. That is a rotator cuff. Infraspinatus and teres minor, both rotator cuffs on the posterior side, they laterally rotate the arm. So obviously those are not answered because they're not medially rotating this arm. Now what you can get confused with is teres major. You may go, oh, that one medially rotates the arm. But the question is asking for a rotator cuff. So the key to this question, the reason I did this is so you remember, look at the question carefully and read it carefully. Because in this case, if you just saw functional deficit, medial rotation of his arm, and which muscle is most likely compromised, and you completely neglect the fact it's actually it's saying a rotator cuff injury, you could have just went for teres major, because it does adduct and medially rotate. And that could have been your first choice without looking at all the other answer choices. So when you come into a rhythm and you're approaching something, keep that approach. So you're not missing things. That's why I'm using the same approach with every question. I'm looking at the question at the end, which muscle is most likely compromised? I'm circling, I'm doing something to memorize what am I looking for. Then I go to the stem and I'm looking for clues. I saw rotator cuff. Then I saw the functional deficit, weakness with medial rotation of his arm. Went back to the question, which muscle is most likely compromised? Look at my answer choices and I can just eliminate multiple ways. I can eliminate by, it's a rotator cuff, so which one's not a rotator cuff? Which one medially rotates the arm and go directly to it? Some of you guys will be able to answer this in a matter of seconds. Some of you may take a little bit. What you want to do is start using the same approach with every question so you don't miss anything. And again, there's multiple ways to skin a cat. So once you figure out your approach, that's what you want to keep using. That's why doing practice questions is very, very, very important when approaching your medical school examinations. Okay, you're going to have to do the same thing with your boards in years to come. All right, so sample question number 4. Let's look at the approach again. So we're going to look at this last sentence. It should say which, but what nerve or nerves innervates the muscle that produces this movement? All right, so we know that we're looking for a nerve, and if you look at the answer choices, you already got that going. So we're looking for the nerve that innervates the muscle that produces this movement. All right, so you're going a little step further here. So look at the stem. A 20-year-old male is struck with a hammer on his forearm. All right, so we know that it's definitely the forearm muscle, okay? Physical examination reveals weakness when flexing digits 2 through 5 at the proximal interphalangeal joints. So we're getting a functional deficit again, but this time we're not being asked what muscle is involved. We're actually being asked what nerve innervates this muscle. So this is not a recall question. This one you have to take a step further. You have to figure out the muscle. That would be your recall question there if it asks you what muscle after giving a functional deficit. And then once you figure out the muscle, you have to figure out what nerve innervates it in its sense, okay? So we got a functional deficit. So we're given a functional deficit and asked what nerve innervates the muscle. So what muscle flexes those digits 2 through 5 at the proximal interphalangeal joints? And that's your flexor digitorum superficialis. All right? If you remember, flexor digitorum profundus flexes the digits 2 through 3 on the distal portion. So flexor digitorum flexes them in the distal interphalangeal joint, not the proximal. So I said 2 through 3. Flexor digitorum profundus flexes the digits 2 through 5 at the distal interphalangeal joints, whereas flexor digitorum superficialis flexes the digits 2 through 5 at the proximal interphalangeal joints. So your clue here, it gives you the weakness or the functional deficit. In this case, you get weakness when flexing digits 2 through 5 at the proximal interphalangeal joints. And this is where reading the question is important, because if you just read flexing the digits 2 through 5 and you misread it as distal, you probably would have thought flexor digitorum profundus, which is innervated by some different nerves, okay? So, what nerves innervates this particular muscle, flexor digitorum superficialis? If you remember from the lecture, it's innervated by one nerve. And if you look on the donor, it's that nerve that's sandwiched between flexor digitorum superficialis and flexor digitorum profundus. All right, and that's your median nerve only, right? So if it was profundus, if you recall, half of it is innervated by median and half of it is innervated by ulnar, right? So if you remember on the hand, the medial digits 4 and 5, those tendons are going to be innervated by the ulnar. And then digits 2 and 3, those are going to be innervated by the median nerve. That's flexor digitorum profundus. So that's one muscle that's innervated by 2 nerves. Obviously, that isn't the answer here because it's talking about the flexor digitorum superficialis, because you're looking at the functional deficit, looking at flexing the digits 2 through 5 at the proximal interphalangeal joints. Okay, so your answer here is only median because it's the flexor digitorum superficialis itself. So again, this is a level 1 question. You're looking at one step further. What I did was I looked at the question itself. What nerve or nerves innervates the muscle? That means I have possibly more than one nerve, right? And if you look at the answer choices, you can see that. I go to my stem and I start looking for clues. I saw that the forearm was injured. I saw that the actual deficit was weakness when flexing the digits 2 through 5 at the proximal interphalangeal joints. So that gives me a clue what muscle is the problem. And then I have to remember one step further, if that's the muscle, what nerve or nerves innervated? And I knew median did it because I remember on the donor it's sandwiched in between the two, and superficialis is only median, whereas profundus underneath him, that also flexes digits, is median and ulnar. But it's talking about the proximal interphalangeal joints. So the key to this stuff is using the same approach and reading the question very, very carefully because you can miss things. All right, let's go to sample 5. Same approach. What nerve is most likely affected? All right, so we know our answer choices are going to have a nerve in it. So we got to figure out what nerve is being involved here using the stem. So now we have a 26-year-old man is stabbed in the left chest during a brawl. Okay, so it's somewhere around the chest area. Physical examination reveals he is unable to raise his left arm above the horizontal position, right? And that horizontal position, as I told you, is about 100 degrees. All right, so he can't lift up his arm above that 100 degrees all the way up, okay? All right, so this is a level 1 again. You're given a functional deficit in this case, and you have to figure out what muscle is affected and what nerve innervates those muscles. It's a different type of approach here. So same kind of thing as before. So let's look at the muscle deficit one more time. In this case, the person has an inability to raise the arm above the horizontal plane. So what muscle raises the arm above the horizontal plane? And if you remember from the shoulder lecture, that would be your serratus anterior. Okay? All right, that's the first step. That's your recall. You're given the functional deficit, you figure out the muscle. You recall the muscle based off the deficit. Now we have to figure out what nerve innervates that serratus anterior. This is the same muscle that gives you that wing scapula, right, guys? So when you push your arms against the wall, it protracts the scapula against the thorax. Or if you raise your arms, same kind of difference. It helps rotate it. But when it's not there, the scapula can actually retract and actually dorsally protrude and look like that wing scapula. Now, in this case, you're only given one clue. You're not given the wing scapula clue. You're given the fact his other movement, which means he's the one that actually raises above 100 degrees. So if you recall when we're talking about the shoulder, the supraspinatus initiates abduction to 15 degrees. The deltoid continues abduction from 15 to 100 degrees. That's your horizontal plane. And the serratus anterior lifts it up above that 100 degrees in itself. All right, so we know it's serratus anterior. Some of you guys probably by now are like, all right, it's long thoracic. That's true, right? Axillary would be your deltoid. So the question somehow said is unable to raise to the horizontal plane, but can initiate abduction, then it's probably your axillary because that would be involving the deltoid. If you remember, axillary also innervates the teres minor. So in that case, the person can also have weakness of lateral rotation of the arm. Lower subscapular, your subscapularis, right? Suprascapular is going to your supraspinatus and your infraspinatus. So in this case, if it was suprascapular, you can have multiple deficits. You can have initiation of abduction to 15 degrees, depending on when the lesion is, or if it's affecting infraspinatus, you can have weakness with lateral rotation as well, right? Thoracodorsal, we've already discussed this before with the latissimus dorsi. So this is the guy that abducts, immediately rotates your arm and even does extension of the arm. Okay? So you can do this multiple ways. I've been giving you functional deficits. A person can give you a nerve that's involved, and then you can work backwards towards a functional deficit or a muscle itself. Okay? This one's a little tougher. Now, I'm giving you a radiograph because a lot of times in the exam, you can have radiographs being shown, and then you have to figure out what's going on. So in this case, you'll see, use this figure to answer the following question in itself. Now, this is a level 2 question. You're given multiple functional deficits within the question, and you're going to have to identify what muscles are involved and figure out what nerve innervates those muscles. So again, looking at the question, what nerve is most likely damaged? So again, we know that it's asking for a nerve this time. The stem itself says a 14-year-old boy fell off a wall onto his outstretched hand, okay, and is in severe pain. Now the X-ray reveals a fractured humor. So let's look at the fracture. So the fracture is right down the middle of the humerus. It's the mid-shaft. Okay, so if you look, it's right here. All right, so it's the mid-shaft. Okay? If it was up here, your head of the humerus is up here, your anatomical neck is right here. If it was about this area, that's your surgical neck, right? So it's a different injury that can occur. But right now, we're looking at the mid-shaft itself. Okay, so right here. All right, so let's continue. So physical examination reveals his wrist is in the flexed position and is unable to extend it. Okay, so that's part of your clue there. It's in the flexed position and is unable to extend it. All right, so he's lost extension of his wrist. But if you move on, there's more deficits. Extension and supination of his forearm is weakened. So he has weakened extension and supination of his forearm. So two deficits, multiple muscles, which is why you have to go a little further than just one muscle and one nerve going through. All right, so what function deficits does this patient have? And that's the loss of wrist extension, that's why his wrist is flexed, and weakness of extension and supination of the forearm. Okay? So what compartment of the arm does the forearm extend from? Or what compartment of the arm does forearm extension occur? So if you recall, you have the anterior and posterior compartment of the arm. The anterior compartment does flexion of the forearm, and of course a little bit of supination of the forearm. And then you go even further, like with coracobrachialis, it does adduction of the arm and flexion of the arm. But what compartment of the arm does forearm extension? That's your posterior compartment. So if you recall, that's your triceps, right? And the triceps is innervated by the radial nerve. All right, so if you're getting an idea of what's going on here, but that's not enough. That's just one actual functional deficit. What compartment of the forearm allows supination of the forearm and wrist extension? Again, you got anterior and posterior, right? Anterior, big picture here. Anterior compartment of the forearm helps with pronation and flexion of the digits and your wrist. The compartment that allows supination of the forearm and wrist extension is, again, forearm, not arm, is your posterior compartment. You have your supinator back there that does supination, and you have your extensors for your wrist, your extensor carpi radialis longus and brevis and extensor carpi ulnaris. All right? Again, the nerve that innervates this is the radial nerve. So looking at this and breaking it down, what nerve is most likely damaged? In this case, it would be your radial nerve. Okay? Axillary is involving the shoulder. If you recall, it involves deltoid and it involves teres minor. So it doesn't do anything with forearm at all. Okay? The median nerve, that's involving the anterior compartment as well as the ulnar nerve. Okay, that's with flexion and so forth and pronation. All right? Your pronators, if you remember, those are all median nerves. And then, of course, if you look at the extensors, the flexors, sorry, you can have median and ulnar going through there as well. So radial is handling the posterior compartment. Okay, it doesn't do innervation of the anterior compartment, it does posterior compartment itself. And you have musculocutaneous. Musculocutaneous is the anterior compartment. So if you had any functional deficits with forearm flexion or maybe supination with biceps brachii, you can have some weakness of supination with biceps brachii because that would help supinate the forearm slightly, right? So those kind of things. So what you want to do is break them down. I'm using the same approach with every question so you get a good idea how to use it. Okay? All right, last but not least, let's clear this up. Let's look at the question now. So last, you have which part of the brachial plexus was most likely injured? Okay, so now we're looking at a brachial plexus. If you look at the actual stem, a 32-year-old patient suffers an injury when painting his house. Physical examination, so overhead movement's more likely. Physical examination shows loss of sensation to his skin on the medial side of his arm and forearm. So now we're getting into sensation as well, not just a functional deficit. This is a sensory deficit. So he's losing feeling to his skin on the medial side of his arm and the medial side of his forearm. That's one deficit. But then if you look further, it says weakness. He also has weakness when abducting, flexing, and medially rotating his arm. So here's where you got to picture that brachial plexus in your head and figure out what part of the brachial plexus can release a nerve that gives me sensation to the medial side of my forearm and the medial side of my arm, and possibly decrease or give me weakness when abducting, flexing, and medial rotating my arm. All right, so I'm going to break this down for you. This is a level 2 question. So you're giving multiple functional and sensory deficits, and you're asked what part of the brachial plexus is damaged, and it involves multiple nerves, if you recall, right? So you can have multiple roots being involved and multiple nerves going through. So look at the sensory first. We're going to break this down one piece at a time. Again, we're thinking about brachial plexus the whole time. And if you look at the answer choices, you're getting an idea. Lateral cord, medial cord, posterior cord, and superior trunk, where C5 and C6 is coming off of. So we have an idea of what's coming through here. All right, so let's think about sensory. So what nerves from the brachial plexus innervate the skin of the medial side of the arm and the forearm? And if you recall, off the medial cord, you have medial brachial cutaneous nerve and medial antebrachial cutaneous nerve. Brachial means arm, antebrachial means forearm, before the arm, right? So those are the two sensory nerves you're thinking about. So you got to think, what do they come off of? And we know that these two nerves are coming directly off the medial corridor. So that's a possible answer. There you go. That's a possibility, but you have to look at it even further. Look at the motor side. So the motor side, what muscle flexes at abducts and immediately rotates the arm? And the best possible answer for that is pectoralis major here. Okay, and obviously you have some muscles that can abduct. You have some muscles that can solely medially rotate, or latissimus dorsi can help medially rotate, right? But it adducts the arm and extends the arm. This guy is flexing, abducting, and medially rotating the arm all at once, but we already know, we have a clue that it's the medial cord because of the sensory that's being lost here, right? And of course, we know the innervation in pectoralis major is medial and lateral pectoral nerve. Now, if you recall, the medial one, I told you it's named after the cord it comes off of. The medial pectoral nerve comes off the medial cord. The lateral pectoral nerve comes off the lateral cord. So at this point, it is possible it could be lateral cord. But you have to take the big picture here, guys. So here you have a sensory deficit and a functional deficit, and you have to match them. You only got a few answer choices here, right? So what part of the brachial plexus they come off respectively? Medial pectoral comes off of medial cord, lateral pectoral comes off of lateral cord. So what's your best possible answer that involves both the sensory and functional deficit this patient has? And in this case, guys, it's your medial cord, right? Because you're actually affecting both the sensory and the functional nerve that comes off of that medial cord. Why isn't it a lateral cord? Well, if you recall, off the lateral cord, the only nerve that's coming off of there is your lateral pectoral nerve. So the only deficit you would most likely have is weakness when abducting, flexing, and medially rotating the arm, right? Why not posterior cord? If you recall, posterior cord, you got your upper and lower subscapular nerve, right? You have thoracodorsal, and I told you earlier, thoracodorsal adducts, extends, and medially rotates the arm. So you don't have that deficit at all here in itself. If you want to go even further, and you go down the terminal branch of the posterior cord, you have radial, that does extension of the forearm, extension of the wrist, extension of the digits, okay, including supination. Or you even have axillary nerve coming off that posterior cord, and that will do abduction of the arm. Can it do this? Yeah, the deltoid can abduct and flex and medially rotate if you're looking at the actual with the middle part and the anterior part of the deltoid. But you got to take it as a big picture. The axillary nerve does not give you sensation to the medial side of his arm or his forearm, nor does anything off that posterior cord. All right, so that one's eliminated for that reason. So yes, you can break it down even further. The superior trunk, right? The superior trunk is suprascapular nerve and the nerve to subclavius. Right, so suprascapular, you got supraspinatus and infraspinatus. So again, initiation of abduction to 15 degrees. Infraspinatus, lateral rotation. None of those are even in this question at all. So what you want to do is, again, look at the question which part of the brachial plexus. And then going into the actual stem, you want to have that in your head. What is the brachial plexus? And look at the answer choice. You can see lateral cord, medial cord, posterior cord, superior trunk. And as you're looking at the question, you can start to see, what are they giving me? Sometimes they give you innervation. Sometimes the question will give you a blood supply. Sometimes the question will give you a muscle. In this case, it's giving you a functional loss and asking you how to approach it. It's giving you the two different functional loss, or functional loss and the sensory loss in this case. So you have multiple things coming off. Okay? Hopefully this helps. Again, anytime you have a question, please come see us. And if it's that particular lecture, you want to go see that lecturer first. And our doors are wide open. So we have an open door policy here, remember? So if you see us and the door's open, you can come see us, or you can always set up an appointment with us at any time. Please do not hesitate. Do not wait till the day before the exam or 2 days before the exam trying to figure out what's going on or how to approach it, or how, if you have a specific question. Please come to us when you start hitting those brick walls at any point in time, so we can help you get over that hump before it's too late. All right? I wish you guys nothing but the best of luck. Hopefully this helps, and I will see you around.